Okay, so Dr. Chia today will talk to us about CT of the neck, emergency settings.
Good morning, everyone. Today we are talking about the CT scan of the neck in emergency settings. As we know, the CT scan of the neck is a very commonly used protocol, and especially in the emergency settings. So we have to have a specific protocol in order to identify each structures in the neck and identify each part of the neck. As we know, the neck is a complex area with many structures inside. We have vascular structures, we have the glandular structures, aerodigestive tract, we have the lymph nodes. So we can identify each of these areas separately, so we can synthesize and hypothesize a final CT reporting which is proper for the emergency settings. As we know, it's used for the acute and chronic conditions, and the acute conditions can be evaluated. And when we evaluate the acute conditions, sometimes we find incidental findings of life-threatening, of a very important or significant underlying condition in addition to the acute setting. The vascular and airway patency is very crucial in order to be examined. And we have a specific protocol in which we divide the neck into 12 areas to be evaluated and reported, in which in the later slides we will recognize it. The indications of the emergency CT of the neck to investigate the acute infection and inflammation, and investigate the aerodigestive compromise referable to the neck, and the neck masses or lymphadenopathy when it results in an acute airway compromise or vascular compromise. So all of them for acute and emergency conditions. And it's shown that most of those emergency setting neck CT scans, they are of good value. They have 87% positivity, which means they are done for a good purpose, and they are done for a good finding and good outcome. And so we can, this is challenging in order to continue this protocol. The 12 areas of the assessment of the neck CT analysis is, first of all, we see the cutaneous and subcutaneous soft tissues, and later we see the aerodigestive tract adjacent soft tissues, and then the teeth and periodontal tissues, which is mostly missed by most of us in the CT scans of the neck, and the sinuses especially, and later on we will talk about, and the thyroid gland. Although the thyroid gland is not so much emergency conditions, but maybe a retrosternal extension or paralysis that occurs, or voice change that may lead to the need for the emergency CT scanning. The salivary glands and the lymph nodes, the vascular structures, the bony air spaces, the cervical spine, the orbits and the image brain, the lung apices, and finally the superior mediastinum. This checklist, it should be present in the final reporting of the CT scan of emergency CT. And each of them, we put it, the heading, for example, cutaneous and subcutaneous soft tissues, and beneath it we write our findings. And in the last, we get the impression, the final impression of the condition. And for example, later on we will talk about some syndromes and some conditions in which we collect the findings from different areas, and it gives us a final impression of the condition of the emergency setting. As we know, we have a checklist also for abdominopelvic examinations, and this checklist for the neck CT protocol is the same as the abdominopelvic. For example, in abdomen we should see the organs, we should see the vascularity, the pelvis, and all other areas. The same in the neck, as we said, we do the systematic approach, and we start our protocol. Whenever it's possible, it should be performed with the IV contrast. It's very important, unless we have a suspected foreign body. In cases of foreign body, usually we don't use IV contrast because it will obscure the findings of the foreign body. Otherwise, we use a protocol neck CT with contrast. And it's very important, especially in the cases of abscesses and in case of vascular structures. So the contrast material is given. We have 60 ml of iodinated contrast material. We inject it over 2 ml per second for 30 seconds. Then after a 60-second delay, we add another 40 ml of the agent, and then the CT image at 2 ml per second again for 20 seconds. Then after a 10-second delay, the imaging is commenced. The CT image, we do it helically. From the level is from the orbital roof up to the aortic arch. and it's given 120 kVp, and the 100 to 300 milliamperes second is used according to the patient's condition. As we know, we change the milliamperes according to the conditions for each patient, and then the exact tube current varying to the patient factors. The thickness of the image, usually it's 2.5 millimeter, and then we use a bone protocol, and we use a soft tissue. And axial sections, we can take it as 0.6 millimeter image by bone and soft tissue protocols, and we send the picture for archiving and the communication systems. This is the procedure how we give the contrast in the case of the neck CT in emergency setting. As an overview of our informations, we have layers in the neck and most superficial fascia, and then we have underneath it the platysma muscle, which is very important in our first entity, the cutaneous and subcutaneous conditions of the neck. And later on we have the deep fascia, deep cervical fascia, which has also superficial and deep parts, and in here it's mentioned as investing layer of the deep cervical fascia. And later on we have, this is the landmark sternocleidomastoid muscle. Beneath it we have the pretracheal layer, and we have a visceral part of the pretracheal layer and the muscular part of the pretracheal layer, and paravertebral areas, paraspinal areas. This is not shown in this image. This is another anatomical reminder for the cervical fascias. It's important to know the anatomical extension of each layer of the cervical fascia, because it extends to the mediastinum, it extends into the mid of the chest, and sometimes the danger space is very important, which is lying between the alar fascia and the prevertebral fascia. This danger space is extending from the base of the skull up to the diaphragm. So any condition it's involving this danger space may extend up to the diaphragm, and may be a life-threatening condition, may present as a mediastinitis and emergency condition. And this is another axial section for the cervical fascia divisions of the neck. We have it's important to know that the carotid sheath, it's made from all three layers of the neck fascia. It's involved, so any fascia involved by any inflammation may extend into the carotid sheath, because the carotid sheath anatomically is made from all the three layers of the neck cervical fascia. And this is a selected image to show the spaces, oral cavity and deep spaces, axial CT scan. As we see, we have a sublingual space and submandibular space. The landmark to differentiate between the sublingual and submandibular is the mylohyoid muscle. The space above the mylohyoid muscle is the sublingual space, while the space below the mylohyoid muscle is the submandibular space. We have another space which is very important, the masticator space. It's lying external to the masticator muscles. And we have the parotid space. As we know, the parotid has a superficial and a deep extension, and this makes it likely to compress the other spaces or to involve the other spaces in the deep base of the skull. Then we have the carotid space, as we know, the carotid sheath. We have the pharyngeal spaces. We have the mucosal pharyngeal space, we have the retropharyngeal space, and we have the parapharyngeal spaces. Here the retropharyngeal space is identified, and it's very important because it's extending downwards again. And the danger space, as we mentioned, is very important also. And we have the paraspinal areas and posterior cervical space and perivertebral spaces. This is another one, the same thing of the spaces of suprahyoid neck. We mentioned most of them. And this is again different sections. We have the coronal sections, we have the axial sections. We look here, we look at this purple in the middle, midline. This is the submandibular space and sublingual space, and the one external to it is the submandibular space. The muscle in between is the mylohyoid muscle, and this is the genioglossus muscle in midline. And we have the median raphe separating the genioglossus muscle, and these are posteriorly. We have the tonsillar spaces. The tonsillar spaces are very important, and later on we will talk about them. And this is the submandibular gland. This is just as a reminder of the normal anatomical landmarks in the CT scan of the neck. And this is the contrast enhanced, the vascularity. We can see the lingual artery passing in the sides of the genioglossus muscles and geniohyoid muscles, and we see that the arteries are medial and the veins are lateral to them, and these are important landmarks also to be considered in the emergency neck CT scans. Now we come to our pathological conditions, and the first part we deal about is the cutaneous and subcutaneous soft tissues. We have conditions called cellulitis. As we know, the involvement of the skin by any chronic conditions, for example by eczema, by psoriasis, by any trauma to the skin, or chronic irritations to the skin, may lead to the inflammation of the skin of the neck. And this inflammation, it will maybe involving the underlying subcutaneous tissue. When it involves the underlying subcutaneous tissue, later on it may develop abscess. And as we know, the abscess anywhere is seen on the CT scan as a hypodense area, hypoattenuating area, and is surrounded by the rim enhancement after contrast. That's why it's important to do the CT scan with the contrast. But in case of cellulitis, it's not usually needed to have a rim enhancement, because sometimes it's just the edema and the inflammatory infiltrations that will be seen on the CT scan. In this case, we see that the CT examination of the head and neck, the soft tissue window, it reveals cellulitis of the masseter and the medial pterygoid muscle on the right side, with the abscess formation in the masseter muscle. We see that there is an hypoattenuating area and there is rim enhancement in the area of the masseter muscle, which is an acute condition and to be dealt with. This is another CT examination of the head and the neck. We have the soft tissue settings, and we have the bone. We can see the bone and soft tissue settings. We see the abscess formation and air bubbles are visible on the left side and the thickening of the left masseter muscle. This is again a case of the abscess formation with air-producing organisms and air-containing organisms. This is also another case, and the examination of the head and neck. We see a soft tissue window, hypodense abscess is seen with a rim enhancing capsule and air bubbles inside the visible in the left temporal space. It's in the left temporal space. This area, yes. It's just, it's not, yes, it's all of them involved, and we can see the air and edematous regions and rim enhancement. We see it with the contrast agent. This is another case with a submandibular gland space abscess. We see it again. We have hypoattenuating area. This is enlarged region with air containing, and we have contrast enhancement. This is another case of the submandibular gland abscess. Another entity in the region of the cutaneous and subcutaneous tissue is the otitis externa. We have a here in this article. It's mentioned otitis, simple otitis externa, which is known as a swimmer's ear. And we have the malignant otitis externa, and we have the necrotizing otitis externa. The acute otitis externa is only involving the external auditory canal and the pinna. It's not extending beyond that. It's not extending to the bony part of the external auditory canal. While the invasive otitis externa, it's involving the bony part of the external auditory canal, which means there may be erosions of the bone, maybe involvement of the inner parts of the middle ear, and so on. The malignant otitis externa is a life-threatening condition, and it may involve the bone, it may involve the temporomandibular joint, it may extend intracranially, it may lead to the venous sinus thrombosis, and so many manifestations. It's usually occurring in the diabetic patients, in immunocompromised patients, and it should be dealt emergency. Necrotizing acute otitis externa, we have history of radiotherapy and malignancy, and extensive involvement. And the neck spaces may be all involved, because you know the radiotherapy is involving a large area of the neck. So it's extensive involvement, it's infiltrative type, and we see the disruption of the fat planes in the case of necrotizing acute otitis externa. And usually we may have manifestations in the mastoid air cells when we have an invasion. So we may have a fluid inside the mastoid air spaces. We have filling of the mastoid air spaces. This is on the left side, we have the simple acute otitis externa, or the swimmer's ear. Look, it's only involving the external part of the membranous part of the external auditory canal, and the cartilaginous, yes, and it's not involving the bony part of the external auditory canal. It's intact, and it's only involving the thickening and narrowing of the canal with the thickening of the pinna. While in this case, it's a type of the necrotizing otitis externa, in which we have opacification of the mastoid air cells, involvement of the bony portions of the external auditory canal, and there may be also underlying involvement intracranially when we do further scanning and further imaging. This one is the sagittal image, which shows this is a thickening of the external auditory canal, which is caused by otitis externa. This is a case of malignant otitis externa of the right ear, and axial enhanced CT image. There is a bone erosion of the anterior wall of the right external auditory canal. We have a bony erosion. Look at the bone in the right side and the bone in the left side. There is a significant erosion of the bone. There will be involvement of the temporomandibular joints, and also we have the there's also erosion of the anterior margin of the glenoid fossa. Also, there's a focus of the gas we see in the next image in the temporal fossa, in the middle cranial fossa, in a section above the previous one. In case of this is another case of malignant otitis externa. We see there is involvement and bony part of the external auditory canal and involving of the temporomandibular joint. Look on that side, the temporomandibular joint space, how it's infiltrated, while in the other side, the temporomandibular joint space, it's less than the right side. This was the conditions of external auditory canal. Another condition, when we look at in the entity of the cutaneous and subcutaneous tissues, is we can see the derivatives of the branchial cleft abnormalities. As we know, the branchial complex, it's an embryological entity in which in the 3 to 5 weeks of the gestation, this develop, and we have 6 branchial arches, and we have 4 to 5 clefts. And each of them we have, this is, it will be ectoderm, origin, mesoderm, and endoderm, as we know from the embryological development. The anomalies result from the branchial apparatus, the 6 arches and 5 clefts. They are embryological precursors of the ear, muscles, blood vessels, bone, cartilage, and mucosal lining of the face, neck, and the pharynx, which means that these branchial clefts, these branchial arches, or pharyngeal arches is sometimes mentioned, this give rise to the muscles of the neck, give rise to the vessels of the neck, give rise to the cartilage and the linings of the face and the neck. During the 3rd to the 5th week, as we said, the second arch grows caudally and covers the 3rd, 4th, and 6th arch. The most common abnormality of the branchial cleft abnormality is the second branchial cleft cyst, which is seen in 90 to 95% of the cases. This is what we mentioned. Either we have in the form of a cyst, or we have in the form of a fistula, or we have in the form of the sinus. A cyst has no connection, as we know, it's a cystic component. The fistula has a connection with another structure, and the sinus has an external connection outside. This is a case of the branchial cleft cyst. We look here, it's a cystic component. We see it as any cystic lesions in the neck. And it's found on the left side with the rim enhancement and fluid content. This is another case of the 4th branchial cleft cyst. And whenever we have a cyst, either the cyst is inflamed or it's not inflamed. Either it's infected or it's not infected. When it's not infected, the fluid attenuation, there's a fluid attenuation, and it has a thin wall. When it is infected, so we have a contrast enhancement and surrounding inflammatory fat stranding. Now we come to the aerodigestive entity. We finished the cutaneous and subcutaneous entities, and now we come to the aerodigestive. Aerodigestive, we start from the epiglottis, and then we come to the larynx and the visualized parts of the esophagus and the trachea. This is a general anatomy which we know it from the previous times of the larynx and the epiglottis. We have the epiglottis. Normally the epiglottis looks as a thin plate, like in this sagittal section, but whenever it's inflamed, it becomes thickened. And the epiglottis, the lining, the mucosal lining of the epiglottis, it is tight beyond the vocal cords. So the extension, we will not see extension of epiglottitis or inflammation of the epiglottis beyond the vocal cords. Usually we see it into the anteriorly because it's loosely bound to the lining of the tongue and lining of the base of the tongue. So in case of the epiglottitis, we usually find the findings anteriorly and superiorly above, and the involvement is not extending beyond the vocal cords. Now, however, the epiglottitis usually it's previously we know it's in children, but nowadays it's more commonly seen in adults, and it has an incidence 1 to 2 cases per 100,000 adults, and it's caused by the Streptococcus pneumonia or viral infection or fungal infection, or due to trauma or due to chemicals. And the CT in the imaging of epiglottitis, they have, as we say, thickening of the epiglottic mucosal folds and ariepiglottic folds and or arytenoids and the other things we mentioned. So it's important to look for the lingual abscess in case of epiglottitis. As we said, the epiglottis is loosely bound anteriorly to the base of the tongue. So whenever there is inflammation, there may be a chance for development of the lingual abscess. So it's important to look for the lingual abscess in case of the acute epiglottitis. This is another case of the epiglottitis. As we see, there is an airway compromise in this patient, narrowing of the airway, and the thickening of the epiglottic folds and ariepiglottic folds up to the base of the tongue. The second case is a severe airway compromise in which there is almost totally occluded, and the patient has a cricothyroidotomy in order to life-saving condition. Another entity in which in the aerodigestive tract when we look for is the tonsils and the peritonsillar area. The tonsils, we have the tonsillar area. This is around the pharynx. This is a palatine tonsil, and this is a lingual tonsil, and it's within the pharyngeal mucosal space. This area is very important to look for because whenever we have a peritonsillar abscess, the abscess will be between the capsule of the tonsil and between the superior constrictor of the pharynx, and it's usually seen superior lateral to the tonsils. This is the tonsillar and peritonsillar abnormalities. In case of tonsillitis, the tonsils are enlarged. They demonstrate a striated enhancement pattern. We have the peritonsillar phlegmon appears as a vague hypointensing area without a well-formed rim or enhancement. CT is 100% sensitive in these cases and 75% specific for the detection of the peritonsillar abscess, in which on the CT most commonly appears as a rim enhancing collection superolateral to the palatine tonsils, as we said. It's here demonstrated well. Hypoattenuating with the rim enhancement is just at the site of the tonsils and left tonsillar area. And these are other cases of peritonsillar abscesses. As we know, this is a patient that looks to be endotracheal tube is put because of the airway compromise. And this is a left peritonsillar abscess. We have a hypoattenuating with a rim enhancement and a superolateral to the tonsillar space, and it's compressing the airway to the other side. This is again, it's another case of the tonsil and peritonsillar abscess on the left side. It's important to assess the distance between the tonsils and the internal carotid artery. Sometimes we have a variation of the internal carotid artery which has a medial course, a very medial course. So whenever we see an abscess, we have to measure this distance because when we do the peroral drainage or when we do interventions, it's important to know where is exactly the vascularities around this abscess in order to avoid traumatic injury to the carotid artery. This is another case of tonsillitis in a 34-year-old man. This is a contrast enhanced image and shows kissing tonsils. We have both tonsils are enlarged and they are almost touching each other and causing an airway compromise. There is a striated enhancement pattern. It's only a tonsillitis and kissing tonsils. It's yet not becoming an abscess. This is a bilateral abscess in a 20-year-old woman, and it's a contrast enhanced image, shows bilateral low attenuation collections with a rim enhancement which is superolateral to the palatine tonsils. we come to another entity. We have the retropharyngeal space. As we mentioned, the retropharyngeal space is the space behind the pharynx, so extending in the behind the nasopharynx, oropharynx, and downwards. The retropharyngeal space also may be involved by an abscess or may be involved by a lymph node, and this lymph node may get infected, may become suppurative, may become an infected lymph node, which may rupture and may cause a retropharyngeal abscess formation. This is a left retropharyngeal suppurated lymph node and retropharyngeal abscess in a 5-year-old boy. And in this image, the lymph node is consistent with internal suppuration. In the B, in the image with the B, we have and the patient's condition is worsened. We look at the edge of the lymph node, it's ruptured on the medial side. So the contents of the lymph nodes are extending into the retropharyngeal space. So whenever we have a suppurative lymph node, it's important to manage the case urgently, because it may become ruptured, and the contents may extend to the retropharyngeal space and may cause extensive findings and extensive condition of the worsening of the clinical condition of the patient. This is again a retropharyngeal and the peritonsillar abscess on the right side. This is look, we see this area all, it's edematous, hypoattenuating area. It's involving the tonsillar region, and it's even involving even posteriorly the retropharyngeal region. So it's both a peritonsillar and retropharyngeal abscess. While the image is on the left side, it's parapharyngeal abscess. As we know, the pharynx, we have just beside it and posteriorly, it's the parapharyngeal space. And this is an abscess which is involving the parapharyngeal space. This is a rare case, I found it. It's a case of the TB that's causing a retropharyngeal abscess, which is atypical presentation. And this abscess is extending, look, from above downwards and up to the superior, even to the superior mediastinum and the clavicular level. And it's involving in different parts and not a continuous one even. So from the level of the nasopharynx down to the level of the supraclavicular fossa, it expands and it becomes two collections in the same position. In the axial CT scan at the level of the C7, we see the abscess located next to the C7, and another abscess next to the cricoid cartilage. We see two abscesses. It's divided into two abscesses. This is again another case of the parapharyngeal abscess. We see a hypoattenuating region with a rim enhancement, compressing the pharynx and defeating it to the other side. This is a figure shows a retropharyngeal edema due to calcific tendinitis of the longus colli. In this condition, we should not miss this condition and misdiagnose this with the retropharyngeal or parapharyngeal abscesses. There are sometimes calcific tendinitis of the longus colli muscles, the prevertebral muscles, in which it leads to the edema. And this is a retropharyngeal edema due to calcific tendinitis. How we differentiate it? We differentiate it, it has a tapering ends, and it extends to both sides bilaterally, and above and downwards it has a tapering end. Look in the next image, it's a tapering downwards. So it's just lentiform, like a lentiform shape. It's extending above and downwards, and it has tapering ends. And we can see the attenuation, the calcific attenuations within the longus colli. Usually we see it when we measure the calcific areas of the longus colli muscle. So it's a case of retropharyngeal edema due to calcific tendinitis of the longus colli muscle. Again, this is another case of the retropharyngeal edema. This is edema associated with acute calcific tendinitis. The same. Another entity. Now we finished the pharyngeal abscesses and tonsillar abscess. Now we come to another entity within the aerodigestive region, is the angioedema. Usually the angioedema in emergency settings is due to the drugs. Usually it's caused by the ACE inhibitors. And in this CT image, it's showing circumferential mucosal and pharyngeal swelling and diffuse stranding of the parapharyngeal and subcutaneous fat bilaterally. We see the subcutaneous fat and the parapharyngeal fat stranding bilaterally. This is an extensive involvement, and the angioedema is either localized, maybe it's only the lip, only the lower lip, or maybe it's diffuse. It's involving the pharynx, involving the subcutaneous tissues, extending downwards. So we have to manage it accordingly. This is actually this is MRI. This is not CT, but it's informative for showing this type of the angioedema and the soft tissue involvement. This is a case showing edema of the lower lip consistent with the angioedema. This is a local focal type of the angioedema, which is seen on a neck CT scan emergency setting. This is another unilateral mass like pharyngeal and laryngeal angioedema. We see this area, we may think of a mass, we may think that this is a mass, but actually this is another case which I found it. It's a case of the angioedema that's involving the pharynx and the laryngeal walls, and it's compressing the larynx and may cause airway compromise. This is an unusual appearance of the drug-induced pharyngeal angioedema. The CT scan revealed large infiltrating hypoattenuated, poorly circumscribed right tonsillar mass like lesion and subtle enhancement extending to the right submandibular region with associated compression of the oropharynx, hypopharynx left to the right airway deviation. The unilateral focal nature of this process placed the AC-induced angioedema lower on our exceptions. They thought that it's a mass, but I read the article later on when they excluded all other causes. The diagnosis was ultimately supported by the rapid resolution. The patient has a rapid resolution after 1 day. 1 day when they examined the patient, after 1 day, nothing was remained. So this put the diagnosis of the angioedema. Otherwise, as I read the case, they thought of mass-like lesions or abscesses, and later on, with the differential diagnosis, they found that it's an angioedema, atypical presentation. Another entity when we look for in the CT of the neck in emergency setting is the foreign body. As we said, in the case of foreign bodies, usually we have 76% of them, they are pharyngeal and esophageal foreign bodies. They are just impacted below the cricopharyngeus muscles. And usually we know that it's either a fish bone or it's a chicken bone or it's a wooden particle. And the bony particles, when it's ingested or it's lodged in the aerodigestive tract, it's seen as a hyper-attenuating and radiodense regions, while the wooden objects in the acute setting has an air attenuation. So we use a lung window in case of the wooden foreign body ingestion in acute condition. But in the chronic, after, for example, 2 to 3 days, it will be mineralized. It's an organic compound. It will be mineralized, and we will see it as a hyper-attenuating foreign body inside the aerodigestive tract. And this is a CT scan of the neck showing a foreign body in relation to the left internal jugular vein in the coronal view and in the axial view. This is again an impacted chicken bone, and the CT image shows in the cervical esophagus posterior to the larynx there is gas within the adjacent left lateral soft tissue consistent with a perforation. So sometimes we find the foreign body, I don't know, I have put the case or not, sometimes the foreign body will migrate in a rare conditions. It will migrate, and you may find it in the paraspinal spaces, in the paraspinal regions. But actually it's a foreign body which was ingested, and it has perforated the esophagus and has migrated, and we can see the air around it, which indicates the perforation of the foreign body. Now we have another entity when it's very important to look for in the cases of the CT scan of the sinuses, which we see many cases in the CT unit, and the sinusitis. Actually, for myself, I haven't looked for the periodontal regions when I look for the sinuses, but it's very important because the teeth and the periodontal tissues, usually they are a cause for the acute sinusitis findings in the CT scan of the paranasal sinuses. As we know, we have the most common infection is the caries, dental caries. The dental caries, it will make a defect on the crown of the teeth, and it will be involving like a channel. Sometimes the crown will be absent because of the severe dental caries. It will be involving reaching to the pulp and may involve the alveolar bony areas, and it may extend into the sinuses and cause a maxillary sinusitis. This is an odontogenic sinusitis, and involving the maxillary sinus because of the condition in the second maxillary molar tooth. And as we know, there are strict artifacts usually caused in these regions, and this may obscure somehow the normal anatomical landmarks. This is again another case of periapical tooth abscess and the spectrum of apical periodontitis. And this is an odontogenic sinusitis. Look, we have the dental caries. The crown is absent. Now it's extending and to the pulp region and extending and eroding the bony layer and extending into the maxillary sinus, causing features of the maxillary sinusitis as a thickening or maybe fluid level or anything else associated with the sinusitis. Again, this is a periodontal abscess and shows asymmetrical soft tissue thickening and medial to the left mandibular ramus, as well as thickening of the left masseter muscle. And there is a lack of contrast enhancement, and abscess cannot be excluded. And the thickening of the left platysma muscle also it's noted. So it's an extensive involvement of the region. Usually it's between the mandibular ramus and the masseter muscle. Usually it's seen another condition. We have the pericoronitis. This is an important condition. This is again an periodontal region involvement in the third molar tooth. In those people, I have one of those cases. I have an unerupted molar tooth and partially covered with a gingiva, and this is it's a predisposing factor, risk factor for development of the periodontitis in this region, and extending into the maxillary sinuses and extending even to the temporomandibular joint regions, because it's very near to those spaces. So we have to consider those patients who have these partial gingival eruptions and when they have findings in the maxillary sinuses. And we have another condition which is known as a Ludwig's angina. Ludwig's angina is also extensive involvement of the subcutaneous tissues and inflammatory processes. This case is showing an inflammatory stranding and fluid in the submandibular and sublingual spaces with or without abscess and gas. Ludwig angina is again a type of the cellulitis. Rim enhancing components are not required to make the diagnosis. As we said, in cellulitis, it's not required always to have a rim enhancement. This is another case of the Ludwig's angina, and there is submandibular and sublingual edema, internal fluid pockets, and consistent with the pus, so it's a pus content. And when possible, we have involvement in sublingual submandibular space should be described because of the implications of this drainage and implications of the management plan. However, owing to associated edema, in this case, this may not always be possible to drain it because it's an extensive involvement with the edema. Now we come to another part of the entities. We finished the emergency conditions. 53 of 89.
So I think because it's very interesting, we don't want to hurry with it.
Okay.
I think we'll continue next week.
Okay.
Better, so that we can process it.
Okay.
Tamam.
Thank you very much.
It's very interesting. Thank you. So.